Just think about healthcare today. Every time you see a doctor, get a test, fill a prescription,
Mm.
there's just this mountain of information being generated.
Oh, absolutely. It's staggering.
And trying to manage all that, make sense of it, use it effectively, it's incredibly complex. Now imagine a system where all that data, every single piece, isn't just stored away, but actively working.
Working to prevent mistakes, maybe.
Basically, preventing errors, tailoring treatment specifically to you, maybe even predicting health issues before they become serious.
It sounds like the goal, doesn't it? Turning that mountain of data, like you said, your heartbeat, your lab results, your history, into actual usable insights.
Insights that really improve lives. And this isn't some far-off sci-fi dream. It's actually being built right now. There's a whole field driving this.
And the investment shows it. You mentioned that stat earlier. Was it over $8 billion back in 2018?
$8 billion US, yeah. Just in digital health deals.
Yeah.
That's a huge indicator of how important this shift is.
It really is a massive shift.
So, welcome everyone to the Deep Dive. Today, we're plunging right into this world, the world of clinical informatics.
It's a fascinating space.
Our mission, really, is to unpack it for you. What is clinical informatics? Why is it suddenly so critical? Who are the people actually doing this work?
And crucially, how does it affect patient care, both now and, looking ahead?
Right. We want to show you how it bridges that gap between really advanced technology and the actual human side of medicine. Think of this as your shortcut to understanding this really vital area.
Okay, so where do we start? Defining it, I suppose.
Let's do it. What is clinical informatics at its heart?
Well, at its core, you could say it's the really broad study of how we apply information technology, IT, within healthcare. It's the digital backbone, really.
The digital backbone. I like that. Is there a more sort of official definition?
Yeah, there is. HIMSSS, it's the Healthcare Information and Management Systems Society. They have a pretty good one. They define it as promoting the understanding, integration, and application of IT in healthcare settings.
Okay. Understanding, integration, application.
Right. And the goal is to make sure clinicians get the support they need and that everything aligns with, industry best practices.
So, thinking beyond the jargon, it's not just about sticking computers in clinics and hospitals. Right. It's more fundamental than that.
Oh, much more. It's about actively using that technology to optimize how care is actually delivered. It's about shaping the processes.
Can you give us a really concrete example? Like, how has this promotion of understanding, as Hims puts it, actually changed things for patients, made care safer, perhaps?
Yeah, definitely. Think about medication errors. That used to be a huge, huge problem. Still can be, of course. But informatics has made a massive difference.
How so?
Well, clinical informaticists studied the entire process. How doctors and nurses order drugs, how the pharmacy prepares and dispenses them, how they're administered to the patient, the whole workflow.
Okay.
Then they design systems to make that safer, like electronic prescribing, e-prescribing is a big one. These systems often have built-in checks.
Checks for what? Like allergies?
Exactly. Allergies, potential drug interactions, maybe the wrong dosage. The system flags it right there for the clinician.
Ah, so it's embedding intelligence into the workflow itself.
Precisely. It's not just about keeping records tidy, it's actively trying to prevent harm by understanding how people work and where the risks are. And it goes way beyond just digital records.
Right.
It covers the methods for collecting data, storing it securely, and then crucially analyzing it, really digging into that data.
And you mentioned it delves into information needs and cognitive processes. What does that mean in practice?
It means understanding what information a doctor or nurse actually needs at the moment they're making a decision. And how do they think? How do they process that information under pressure?
So it's trying to match the tech to how people's brains actually work in a hospital setting.
You got it. And that leads to designing tools that really support clinical decisions. Things like summarizing complex patient histories quickly, using visualizations, graphs, charts to show trends.
Making complex data easier to grasp instantly.
Yes. And providing quick access to the latest medical evidence, or even offering active decision support alerts right when they're needed.
It sounds like a massive coordination effort, getting the right info to the right person at the right time in a format they can actually use.
It is incredibly complex, and that's a huge part of what informaticists do. They optimize that flow of information. They work to make sure it fits smoothly into the real day-to-day workflows of doctors, nurses, and patients, too.
Patients as well. How so?
Through things like patient portals, for example. Giving patients access to their own records, appointment scheduling, secure messaging with their care team, it's all part of that information flow.
Okay, that makes sense. And the ultimate goal is always.
Patient safety and quality of care. Maximize those. And underpinning all of this is the work they do in establishing the actual infrastructure, the methods, the policies for how information is handled.
Which must include things like privacy and security. Hugely important with health data.
Absolutely critical. Ensuring patient data is protected is paramount. And, what's really striking is just how fast this field is growing and evolving.
That $8 billion figure certainly suggests that.
It really does. And we're seeing this huge surge now in adopting AI, artificial intelligence, and machine learning, ML.
How is AI changing things in clinical informatics?
It's making tools like clinical decision support potentially much, much more powerful. AI can analyze vast amounts of data to find patterns humans might miss, potentially predicting risks or suggesting diagnoses with higher accuracy.
Wow.
And this ties into other big trends, too, like the growing focus on social determinants of health. Things like income, education, where you live, and how they impact health outcomes.
So informatics is helping us understand those broader factors.
Potentially, yes, by integrating different kinds of data. And it also supports the move towards more patient-driven care, where patients are more active partners in managing their health.
It feels like these informaticists need to be bilingual almost, speaking the language of technology and the language of healthcare.
That's a perfect way to put it. They're absolutely crucial translators within the whole healthcare team. They bridge those two worlds.
So who are these translators? What kind of backgrounds did they come from? Is it mostly IT people who learned about medicine or?
Actually, it's a real mix. They come from a hybrid of clinical professions. You have physicians, definitely, but also nurses, pharmacists, lab specialists, people from radiology, many different clinical backgrounds.
That's interesting. So they bring that frontline clinical experience to the technology side.
Exactly. That clinical perspective is invaluable for designing systems that actually work in the real world.
Now, something that might surprise people is the role of nurses in this field. You mentioned they were pioneers.
They absolutely were. It's a really important point. Nurses carved out a significant role in clinical informatics very early on.
How early?
Their specific certifications in nursing informatics started way back in 1992.
92. Wow.
Yeah. That was, over 20 years before physicians really established their main board certification pathway through AMI, the American Medical Informatics Association, which came around 2013.
So nurses were formally recognizing this specialty decades earlier. Why do you think that was?
That's a great question. I think part of it is that nurses have always been deeply involved in coordinating care, managing information flow at the bedside, and documenting patient progress. They saw the potential, perhaps, very early on for how technology could support and improve those core nursing functions. They were already managing complex information streams.
That makes a lot of sense. And getting these certifications, whether it's for nurses, physicians, or others like the HIMSS ones, KHIMSS, and CPMs, that seems like a big deal in the field.
It really is. It's seen as a, quote, highly visible quality indicator. It signals a certain level of expertise and commitment. It also helps with recognition among peers and employers.
Are the pathways to getting certified very different for, say, a nurse versus a doctor?
They can be, yeah. It reflects the different roles and training backgrounds. For example, for the informatics nursing certification, you typically need a baccalaureate degree in nursing, plus a certain number of practice hours, often around 2,000 hours, specifically in informatics nursing.
Okay. And for physicians?
For the Clinical Informatics board certification for physicians, the requirements are different. You need an MD or DO degree, of course. And then eligibility often comes through either completing a 2-year accredited fellowship program in clinical informatics.
Right, specialized training.
Or through demonstrating significant practical experience, maybe something like 36 months working at least 25% of their time on informatics activities.
So a fellowship or substantial on-the-job experience.
Exactly. And even the duration of the certification can differ. Nursing informatics certifications often need renewal every 5 years, while the physician board certification typically lasts 10 years before requiring maintenance.
Interesting differences. It really shows there isn't just one single path into this field.
Not at all. It underscores the breadth of expertise that's feeding into clinical informatics from all these different clinical areas.
And this expertise isn't confined to one country, is it? You hear more and more about health data moving globally. Clinical informatics feels like it has to be a global endeavor.
It absolutely is. It's rapidly growing worldwide. And you hit on a key point. Patient health data does often cross borders now. maybe for specialized treatment or research, or just because of how cloud services work.
Which must raise huge questions about laws and regulations.
Oh, definitely. You need a deep understanding of international law regarding data usage, data privacy, patient rights. It's complex. You have to consider the rules in the country where the data originated and wherever it might be stored or accessed.
Thinking about that, what are the big implications for us, as potential patients? If my data is being accessed in another country,
Well, the key things are ensuring security, maintaining privacy according to agreed standards, think GDPR in Europe, for example, and making sure that data movement doesn't hinder your continuity of care. It needs to be seamless and safe.
are there organizations working on these global challenges?
Yes, several. AMA, which we mentioned, has a global health informatics working group, the GHIWG. They do important work, especially collaborating with resource-constrained countries to help them build up their informatics capacity and usage.
So helping developing nations leverage these tools too.
Exactly. And HIMSS, although it started in North America, has really expanded its reach. They offer specific certifications tailored for other countries, like the CPMCA for Canada, and they're establishing new chapters all over the world.
Building a global community.
That's the idea.
Yeah.
And there was a really significant collaboration between the EU and the US called the eHealth Work Project. It finished up around 2018.
What did that project achieve?
It was really instrumental in trying to bridge the understanding of informatics skills and workforce needs across the Atlantic. They did a lot of work mapping competencies.
And what did they find? Were there gaps?
They identified 10 key gaps, actually.
Hmm.
But perhaps the most critical one they highlighted was the need for more clinical informatics education, specifically targeting nurses, physicians, and the educators who train them, a real call to boost training globally.
Did they offer any tools to help with that?
They did. They developed something called the HIT CopyMP Tool 2.0. It's this incredibly comprehensive framework. It details over 1,000 different competencies needed for various informatics roles.
1,000 competencies.
Yeah, it's detailed. And it covers something like 250 different healthcare roles. What's really impressive is that they made it available in 5 different languages.
Wow. That's a serious resource for standardizing training globally.
It really is a testament to that international effort to kind of level up the field everywhere.
Speaking of standardizing, let's talk about language. Not just English or French, but the language within healthcare informatics. Making sure the IT folks and the clinicians are actually speaking the same language. Seems basic, but crucial.
Oh, absolutely fundamental. Non-negotiable, really. A shared vocabulary is vital for everything to work smoothly and safely.
What kind of vocabulary are we talking about?
Well, it goes beyond just knowing common medical terms. Like, everyone in healthcare probably knows cardio relates to the heart or derma to the skin.
Or abbreviations like PO for medication by mouth or STAT for immediately?
Right. Those are common clinical shorthand. But there's also a whole set of healthcare IT terms that both sides need to understand.
Such as?
Things like HIPAA, for instance.
Yeah.
Anyone dealing with U.S. patient data absolutely needs to understand HIPAA regulations around privacy and security.
Okay, that's a big one.
Or HL7, we mentioned that briefly. That's a critical standard for interoperability. It's what allows different software systems in a hospital or clinic to actually exchange information meaningfully, like letting the lab system send results to the main electronic health record.
So HL7 is like the universal translator for health systems.
In a way, yes, a very important one. And then there's ICD-10.
Ah, the coding system.
Exactly. The International Classification of Diseases, 10th revision. It's used globally for coding diagnoses and procedures, which is essential for billing, tracking diseases, research, everything. Understanding these terms, IPEA, HL7, ICD-10, and many others, is vital for informaticists and for the clinicians interacting with these systems.
So shared language, shared understanding.
Yeah.
It all feeds into the bigger drive for quality and safety in healthcare, right?
Absolutely. And that drive really gained momentum or maybe urgency after a landmark report back in 1999.
You mean the Institute of Medicine report? To err is human?
That's the one. It was a bombshell. It laid bare just how many medical errors were happening, the staggering financial cost, but more importantly, the tragic human cost, the loss of life due to problems within the healthcare system itself.
It really was a wake-up call.
A profound turning point. It showed that errors weren't usually down to bad individuals, but often due to faulty systems and processes. That report fundamentally shifted the focus towards system improvement.
And subsequent laws, particularly in the U.S.? built on that.
Yes. Laws like the HISI-Tech Act around 2009 were huge. It provided significant financial incentives for hospitals and clinics to adopt electronic health records, EHRs.
Trying to digitize everything.
Right. Get the data electronic so it could be used more effectively. And then the Affordable Care Act, the ACA, also put a heavy emphasis on value-based care, focusing on improving patient outcomes and safety while controlling costs.
So less focus on just volume of services, more on quality.
Exactly. And this whole environment paved the way for things like electronic clinical quality measures, ECQMs.
ECQMs, what are those exactly?
They're specific metrics defined largely by CMS, the Centers for Medicare and Medicaid Services, that healthcare providers report on electronically, usually pulling data from their EHRs. They're designed to track performance on various aspects of care.
Like what kind of aspects?
Oh, a whole range. Back in 2019, for instance, the goals for these measures focused on areas like patient and family engagement, patient safety itself, care coordination between different providers, population health management, using resources efficiently, and clinical process effectiveness.
So trying to measure performance across the board.
Pretty much. It's all about using data to drive improvements in those key areas.
Are there specific organizations that sort of shepherd this quality improvement work, setting standards?
Yes, definitely. In the U.S., the National Quality Forum, or NQF, is a major role. They play a crucial role in endorsing national standards for quality measurement and reporting. They help decide what should be measured and how.
Okay, NQF sets the standards.
And then you have the Agency for Healthcare Research and Quality, AHRQ. That's a government agency, part of Health and Human Services. Their mission is all about supporting research to make healthcare safer, higher quality, more accessible, equitable, and affordable.
What kind of things does HRQ do?
They fund research, but they also develop practical tools and resources based on that research. They have some really impactful initiatives.
You can give an example.
Sure. One is Project Echo. It's a model that uses telehealth technology to train primary care clinicians, often in rural or underserved areas, to manage complex health conditions that they might normally have to refer out. It essentially brings specialist knowledge to local communities.
Spreading expertise through technology.
Exactly. Another great example is their work on the Re-engineered Discharge Protocol, or RED.
Re-engineered discharge. What does that involve?
It's a structured process designed to make sure patients understand their condition, medications, and follow-up plans before they leave the hospital. It often involves follow-up phone calls, too. And studies have shown it can reduce hospital readmissions by as much as 30%.
30%? That's huge.
It really is. It shows how focusing on communication and process, supported by informatics principles, can make a massive difference. And clinical informaticists are right in the thick of this.
How so? What's their role with these metrics and initiatives?
They're often the ones implementing the systems to track these ECQMs, analyzing the data to see where performance is lagging, and then working with clinical teams to redesign workflows or implement tools like the RED protocol to improve those metrics. Whether it's tracking the average daily patient census, monitoring rates of cervical cancer screenings, or reducing infections, they use data to drive tangible improvements in both clinical effectiveness and operational efficiency.
Okay, so we have all this data, these quality measures, this drive for improvement. How does it actually help the doctor or nurse at the bedside in the moment they're making a decision?
That brings us right to clinical decision support, or CDS. This is where informatics can have a really immediate impact on care.
Clinical decision support, CDS. Define that for us.
At its simplest, CDS is about providing patient-specific clinical information, usually filtered or interpreted, directly to a healthcare provider right at the point of care when they're making a decision.
So targeted advice or information right when it's needed.
Exactly, and it's evolved dramatically. The earliest forms back in the late 1950s were really basic mathematical models trying to help with diagnosis, kind of primitive by today's standards.
And now, what does modern CDS look like?
Now we're using much more sophisticated tools. We talked about AI and machine learning. We're using application programming interfaces or APIs to connect different systems. And there are important standards like SMART on FHR.
Okay, SMART on FHIR. That sounds technical. Can you give us the quick, plain English version? Why is that important for CDS?
Yeah, sure. So FHIR stands for Fast Healthcare Interoperability Resources. Think of it like a modern web standard, but specifically for exchanging healthcare information. It makes it much easier for different systems to share data in a structured way.
Okay, FHIR is the common language for data.
Pretty much. Then SMART, SMART, is a set of open standards built on top of FHIR. It basically allows third-party applications apps to securely plug into electronic health records, or EHRs, and access data using that FHIR language.
So it lets developers create apps that can work with different EHR systems.
Exactly. That's the breakthrough. Before Smart on FHIR, if you built a cool app, say, to help manage diabetes, you might have had to rebuild it completely for each different hospital's EHR system. Now you can potentially build it once using these standards, and it can connect to any EHR that also supports them.
That must really open the door for innovation in CDS tools.
Huge potential. It allows specialized apps maybe for specific conditions or improved visualizations or patient-facing tools to integrate much more easily into the clinical workflow via the EHR. It lowers the barrier to getting useful tools into the hands of doctors and patients.
Got it. So SMART on FHIR helps deliver better CDS. And the impact of getting that right information at the right time, it must be significant.
Potentially profound. Imagine getting an immediate alert about a critical drug interaction before you finalize the prescription, or seeing evidence-based treatment guidelines pop up when you enter a specific diagnosis. It can make a real difference.
And making these complex CDS systems actually work well in a busy hospital or clinic, that must fall heavily on the clinical informaticists.
Absolutely paramount. They are the bridge. They understand the clinical workflows, how doctors actually work, what information they need when, and they understand the technology. They translate those complex workflows into effective CDS design and build.
And that translation is key for...
For acceptance and adoption. If the CDS isn't designed well, if it interrupts workflow, if it's not relevant, clinicians simply won't use it. Or worse, they'll find workarounds that might introduce new risks. So that informaticist's role in design is critical.
But there must be challenges in implementing CDS effectively.
Oh, huge challenges. One of the biggest is simply keeping the clinical content within the CDS up to date.
What do you mean by content? The medical knowledge?
Exactly. The guidelines, the drug information, the evidence, it changes constantly. But there's this well-known, frankly shocking statistic.
Oh, what is it?
It's estimated that it can take, on average, up to 17 years for new findings from translational research that bridges basic science and patient care to actually become part of routine clinical practice.
17 years?
Right.
That's almost a generation in medical terms. Why such a huge delay?
It's a combination of factors. There's the time needed for rigorous testing, validation studies, getting regulatory approvals if needed. Then there's the challenge of disseminating that new knowledge effectively to millions of clinicians, changing established habits and protocols, updating educational materials. It's a slow, complex process.
So patients might be missing out on the best available treatments for nearly 2 decades.
That's the implication, unfortunately. And it's a massive problem that informatics and CDS are trying to address. How can we shorten that cycle? How can we get validated new knowledge embedded into clinical tools much faster?
And isn't medical knowledge itself growing incredibly fast?
Exponentially. Some estimates suggest that the volume of medical knowledge doubles roughly every 8 years now, maybe even faster.
So the gap between what is known and what's routinely practiced is potentially widening.
It's a constant battle. And it highlights why just having a CDS system isn't enough. It needs constant feeding, constant updating. It ties back to that famous quote by W. Edwards Deming, the quality guru.
Which one?
A bad system will beat a good person every time. No matter how dedicated the doctor or nurse, if the system they're working in, including the information systems, is outdated or poorly designed, it's going to hinder their ability to provide the best care based on current knowledge.
A sobering thought. So CDS has huge potential benefits. Better quality, fewer errors, more efficiency, maybe even better satisfaction for clinicians and patients.
Yes, all those are potential upsides when it's done well.
But it also comes with significant downsides or challenges if not implemented carefully.
Absolutely. One of the most talked about is alarm fatigue or alert fatigue.
Too many notifications.
Exactly. If clinicians are constantly bombarded with alerts, many of which might not be truly critical or relevant in that specific context, they start to tune them out. It's like the boy who cried wolf. They might ignore the important alert when it finally comes.
Which could be dangerous.
Very. And poorly designed or excessive alerts can definitely contribute to clinician burnout, which is already a massive issue in healthcare.
What other downsides are there?
Data integrity issues can undermine CDS. If the underlying data feeding the alerts is wrong, maybe due to those auto-population errors we talked about or incorrect entries, then the advice the CDS gives could be wrong or even harmful.
Garbage in, garbage out.
Precisely.
Hmm.
And sometimes the fundamental design is just flawed, or the implementation process is rocky, leading to poor adoption or unintended consequences.
So how do you design CDS effectively to maximize the benefits and minimize these risks? Is there a guide for that?
There is actually a really useful framework, often cited as best practice, including by AHRQ, is known as the 5 rights of CDS.
The 5 rights. Okay, what are they?
It's a checklist, essentially, to guide good CDS design. First is the right information,
Meaning?
meaning the information provided should be based on solid evidence, recognized guidelines, be accurate and relevant to the clinical task at hand, not just random facts.
Okay, right information. What's second?
Second is delivering it to the right person.
The clinician making the decision.
Yes, but potentially others too. It needs to reach the specific individuals, whether it's a doctor, nurse, pharmacist, maybe even the patient sometimes who need that information to make a decision or take action.
Right person.
Got it. Third,
Third is providing it in the right intervention format.
format, like how it looks.
Exactly. Should it be a passive alert that just displays information? An actionable alert that requires a response?
Mm-hmm.
Maybe it's better presented as part of an order set or embedded in documentation templates, or maybe just an info button they can click if they want more detail. The format matters for usability.
Makes sense. Format needs to match the need.
Fourth is delivering it through the right channel.
Channel, like the computer screen.
Often, yes, the EHR is a primary channel, but it could also be delivered through a secure mobile app, integrated into a health information exchange system, or even delivered via a patient portal. Where does the user encounter this information?
Right, channel. Okay, and the fifth? Right.
Finally, and maybe most importantly, it has to be delivered at the right time in the workflow.
Timing is everything. Absolutely critical. If the alert comes too early, before the clinician has all the context, they might ignore it. If it comes too late, after the decision is already made, it's useless. The CDS needs to integrate seamlessly into the clinical workflow at the precise moment it can have the maximum positive impact without being overly disruptive.
Right information, right person, right format, right channel, right time. That's a great framework.
It really helps focus the design process on user needs and workflow integration. And as CDS increasingly leverages AI and machine learning for more complex analytics, sticking to these core principles will be even more vital to ensure these powerful tools are used safely and effectively.
It really comes back to the data, doesn't it? Clinical informatics is just fundamentally about clinical data, how we get it, how we store it, and ultimately how we use it intelligently.
Couldn't agree more. It's all about the data story.
And part of using it intelligently is understanding outcomes. You mentioned clinical outcomes and operational outcomes earlier. Can you break those down a bit?
Sure. Clinical outcomes are the direct measures of change in a patient's health status. Things like, did their blood pressure improve? Did they need to be readmitted to the hospital within 30 days? Did they acquire an infection like a CUTI, a catheter-associated urinary tract infection while in the hospital? These are direct measures of care quality and effectiveness.
Okay, so direct impact on patient health and operational outcomes.
Those relate more to the efficiency and effectiveness of the healthcare processes themselves. Things like, did we reduce patient wait times in the emergency department? Did we improve the diversity of our staff recruitment? Did we streamline the billing process to reduce errors? It's about making the system run better.
Improving the engine of healthcare delivery.
Exactly. And often, improving operational outcomes can lead to better clinical outcomes, too. They're interconnected.
And when designing projects or interventions to improve these outcomes, there's that SMART acronym that often comes up.
Ah, yes. SMART goals. Very useful. It stands for specific, measurable, attainable, realistic, and timely.
Can you quickly walk us through that?
Sure. Specific. Your goal should be clear and well-defined, not just improve patient safety, but maybe reduce medication errors involving anticoagulants on Ward 5B by 20%. Measurable. How will you track progress? You need concrete metrics, like that 20% reduction. Attainable. Is the goal actually achievable with the resources and time you have? Realistic. Is it relevant to the broader mission? Does it make sense in the current context? And timely. Set a deadline. Reduce those errors by 20% within the next 12 months. Using SMART helps ensure your improvement efforts are focused and trackable.
That seems essential when dealing with complex systems and data.
Hmm.
But you mentioned earlier, just having the data isn't enough. Data integrity is key.
Oh, it's absolutely critical. And it's a constant challenge in healthcare. You'd be surprised how often data integrity issues pop up.
Like what kind of issues are common?
Well, there's the scary one, wrong patient data, information accidentally getting documented in the wrong patient's chart. That can have serious consequences. Then there are simple fat finger errors, just basic typos when entering numbers like a dosage or a lab value. A misplaced decimal point can be disastrous.
Wow, yeah.
And then there's just missing data. Maybe a clinician was too rushed to document everything completely. Maybe there was a system glitch. Maybe the workflow makes it hard to capture certain information consistently. Incomplete data makes analysis really difficult, sometimes impossible.
So before you can even think about fancy analytics or AI, you have to have good, clean, reliable data.
Absolutely. Data quality management is a huge ongoing part of clinical informatics. Ensuring accuracy, completeness, consistency, it's foundational.
Okay, so assuming you do have reasonably good data, what kind of tools do informaticists actually use to analyze it and turn it into those insights we talked about?
It's a whole range of tools, honestly. It can start with surprisingly common software like Microsoft Excel. For certain types of analysis, especially smaller data sets or quick explorations, spreadsheets are still very useful.
So not always super complex software.
Not always. But for larger, more complex analyses, they definitely move to more specialized tools. Things like dedicated business intelligence or BI, software tools like Tableau, Power BI, Click. These are great for creating interactive dashboards and visualizations.
Helping people see the patterns in the data.
Exactly. And then for more advanced statistical analysis or predictive modeling, they might use statistical packages like SPSS or SAS, or programming languages popular in data science like R or Python with specific libraries.
So a whole toolkit depending on the job.
Right. The overall goal, regardless of the tool, is to transform that raw, sometimes messy data into actual knowledge, into insights that can inform decisions.
And this analysis can look backwards or forwards.
Both. A lot of it is retrospective analysis, looking back at historical data to understand what happened. Why did readmission rates spike last quarter? What are the characteristics of patients who develop complications?
Learning from the past.
Yes. But increasingly, the focus is also on predictive modeling, using that past data to forecast what might happen in the future. For instance, using historical financial data and patient volumes to predict budget needs for the next fiscal year.
Or predicting disease outbreaks.
Exactly. Using patterns in current patient data, maybe combined with public health data, to anticipate potential outbreaks of flu or other infectious diseases, allowing hospitals and public health agencies to prepare resources, staffing, and interventions proactively. These tools are really essential for optimizing how healthcare operates and improving care quality.
This has been a really fascinating journey through clinical informatics. It's clear it's so much more than just IT and hospitals. It really is that crucial connection, that bridge between the power of technology and the practice of compassionate, effective healthcare.
It truly sits at that intersection, trying to make sure all this amazing technology actually serves the ultimate goal: better patient health and safety.
And the clinical informaticists themselves, these translators as you call them, coming from nursing, medicine, pharmacy, they're the ones orchestrating this complex interplay of data, systems, workflows, and people, ensuring quality, driving efficiency, and ultimately safeguarding patients.
It's a challenging but incredibly rewarding field, constantly evolving.
So as we wrap up, here's something to think about. We've talked about the incredible speed at which medical knowledge is growing and how technology like AI is advancing just as fast. We're generating more health data than ever before in human history.
An absolute deluge of data.
So the question I want to leave our listeners with is this. Given this sheer volume and velocity of information, how do we as individuals, as patients, as a society, make sure that all this data, all this technology, truly serves to empower and protect the patient? How do we ensure it doesn't end up overwhelming the system, creating new inequalities, or becoming a barrier rather than a bridge to better care?
That's the critical question for the future, isn't it? How do we keep the human element, the patient, firmly at the center of this technological revolution in healthcare? Something definitely worth pondering.